This very short voiceover PowerPoint is going to be concerned with idiopathic thrombocytopenia purpura, or ITP, agranulocytosis, and polycythemia. Now, the learning objectives include identification of the scientific basis for ITP, agranulocytosis, and polycythemia, identification of therapeutic interventions for these given diseases so we can promote well-being in individuals, and to utilize critical thinking skills in caring for these patients. The two forms of thrombocytopenia that we're going to consider are TTP and ITP. Now, if you remember, thrombocytopenia is a reduction of platelets below 150,000. Manifestations range from prolonged bleeding, from just minor trauma, to spontaneous bleeding without even an injury. Immune, idiopathic, thrombocytopenic purpura is a syndrome of abnormal destruction of circulating platelets. Now, if you remember, platelets normally last about 8 to 10 days. In ITP, they only last 1 to 3 days. It is the most commonly acquired thrombocytopenia. It is an autoimmune disease, but its cause is unknown. The pathophysiology of this is that platelets become coated with antibodies. They function normally, but the coated platelets are destroyed when the spleen recognizes them as being foreign. Hence, they're only around 1 to 3 days. Clinical manifestations include bleeding. There can be mucosal bleeding, such as epistaxis or gingival, cutaneous bleeding with petechiae, ecchymoses, and these occur after routine procedures. And there can be internal bleeding with signs and symptoms of blood loss, which, as you know, is tachycardia, hypotension, and increased respiratory rate. Now, how severe this autoimmune process is depends upon assessment of the skin and mucous membranes. A less severe form, the patients may present with widespread petechiae and ecchymosis. There may be oozing from a venipuncture site, gingival bleeding, or hemorrhagic bulla. In the more severe form, there's a suggestion of intracranial hemorrhage, and you all should be very familiar with this. Signs and symptoms that this patient may have are headache, blurred vision, decreased level of consciousness, hypertension and bradycardia, or retinal hemorrhage. Now, the diagnosis of ITP is made when low levels of platelets are found on a peripheral blood smear. ITP has no cure. In fact, it may occur many years after successful medical management. Treatments include corticosteroids, IV immune globulins, which block the activities of macrophages and prevent the attacking of platelets, rituximab, which is a monoclonal antibody that eliminates B cells involved in autoimmune disease. These patients may need platelet transfusions and a possible splenectomy. Now we're going to look at nursing care after we talk about TTP, which is next. TTP is a syndrome characterized by hemolytic anemia, thrombocytopenia, neurologic abnormalities, fever, and renal abnormalities. It is enhanced agglutination of platelets, which lead to microthrombi that deposit in arterioles and capillaries. Thus, bleeding and clotting occur simultaneously. The cause of primary TTP seems to be linked to a severe deficiency of a protease labeled ADAMTS13. There are cases of secondary TTP, usually caused by drug therapy, including chemodrugs or antiplatelet agents such as ticlodipine. In this case, the physician will stop the offending drug. Clinical manifestations are going to be the same as ITP. There's going to be bleeding, but there's also going to be thromboses in the smaller vessels, and in the brain they'll have headache, confusion, difficulty speaking, and numbness. And if it occurs in the kidney, they may have hypertension or renal insufficiency. The treatment is fresh frozen plasma exchange, high-dose prednisone, and possible splenectomy. It is diagnosed by a platelet count, looking at their PT-PTT, bone marrow analysis, and a monitoring of their hemoglobin and hematocrit. Just to review, ITP is treated with corticosteroids, platelet transfusions, immune suppressants, IV immunoglobulin, danazol, and maybe a splenectomy. TTP is treated with plasmapheresis, high-dose prednisone, and or a splenectomy. Now, nursing implications, we're going to talk a little bit more about these, but include safety, bleeding precautions, and proper transfusion protocol. Now, pooled platelets are platelets from several donors. The problem with these becomes the recipient exposure to bacterial infection. So possibly they're going to use platelets that have been pheresed, which are single donor platelets. Either of these may be irradiated, which helps to eliminate any white blood cells in the donor platelet pool. The healthcare provider may order these different collections of platelets and have them irradiated, and it's very important that before transfusing them that you check to see what type of platelets they are and if they've been irradiated if the doctor orders that. Now, nursing interventions are several, and I'm going to give them all to you. First, you're going to assess the patient for any signs and symptoms of unusual bleeding, such as epistaxis, hemoptysis, gingival bleeding, or purpura. You're going to monitor platelet and coagulation test results and report any abnormal values. Avoid any intramuscular or sub-Q injections. Apply gentle, prolonged pressure to venous and arterial sites that may be oozing or at bone marrow aspiration sites. Avoid any rectal medications, enemas, or vaginal douches. Avoid cutting nails or shaving with a sharp blade. Provide semi-solid or a liquid diet. Encourage the patient to take adequate fluid to avoid constipation. Tell them to use a soft, bristled toothbrush and avoid dental floss. Check the blood pressure only when necessary, and instruct the patient to avoid nose blowing and keep their nasal mucosa hydrated. Transfuse your blood cells using protocols. Monitor intake and output carefully to evaluate renal function. Monitor for side effects of the prescribed meds. Instruct the patient to avoid contact sports and other activities that might cause injury. Instruct the patient to avoid some meds that increase bleeding tendencies, such as aspirin and ibuprofen. Tell them not to walk in bare feet, and instruct the patient to avoid wearing tight clothing. The next blood dyscrasia we're going to look at is agranulocytosis. Agranulocytosis is sometimes equated with neutropenia, but neutropenia is actually only a decrease in neutrophils, whereas agranulocytosis is a decrease in neutrophils, eosinophils, and basophils. In either case, what you want to know is the absolute neutrophil count, which is the total neutrophils times the white blood cell count. For example, if your neutrophils were 0.60 and your white cells were 5,000, the absolute neutrophil count would be 3,000. So why do we need to know this? Well, keep in mind, when the absolute neutrophil count falls below 500, there can be life-threatening illnesses. An absolute neutrophil count of less than 1,000 but greater than 500 is considered to be mild. An absolute neutrophil count of less than 500 but greater than 100 is considered to be moderate. Whereas if the count is less than 100, is profound or severe. Now, to assess these patients, you're usually going to do a history and physical. And they present with an infection, naturally, because they are without an immune system. Patients with agranulocytosis have an onset of sudden malaise, along with a sudden onset of fever and chills. They may have stomatitis or pharyngitis. The fevers can reach 40 degrees centigrade or higher, and the stomatitis may present as a painful ulcer. Sepsis may also occur with tachycardia, increased respirations, and/or hypotension. So as far as doing a diagnosis, you're going to want to look at lab studies, which include WBCs, cultures, and bone marrow biopsies. If TTP is caused by an offending pharmacologic agent, the physician is going to remove it. You're going to treat the infection with appropriate antibiotics. You'll give antipyretics for fever and filgrastim, which is which stimulates the production of white blood cells. It is given sub-Q or IV, usually on a daily basis, until neutrophils reach 10,000. It must be refrigerated. It can cause bone pain, an elevated LDH and alkaline phosphatase, tenderness at the injection site. If the patient is taking injections at home, they must inform the MD if they have a fever of 100.4 or higher, or they get chills. Also, if they have shortness of breath, tachycardia, which we're going to tell them, rapid heartbeat, bleeding that does not stop, or new rashes. Now, if they're in the hospital, they're going to be put on neutropenic precautions or reverse isolation. Now, keep in mind that most infections they are finding are endogenous to the patient, and they really don't think there's a lot of evidence for these neutropenic precautions. However, I'm suspecting this will end up on NCLEX, so I'm going to give them to you. A private room is preferred with strict hand washing by everybody. Staff and visitors who are ill should not be with the patient. And vital sign equipment must be cleaned by central processing, then remain at the bedside. There can be no fresh flowers or plants. You need to change stagnant water frequently, such as what is in denture cups. No rectal temps or meds. No raw meats, fresh fruits or vegetables. No deli foods. No raw or partially cooked eggs. And the patient must wear a mask when they go out of the room. Now, polycythemia is going to be our last blood dyscrasia that we're going to discuss. It is most common in middle-aged Jewish men. There's an overproduction of erythrocytes, leukocytes, and thrombocytes. Think thick, viscous blood. Now, some people actually want to induce this in themselves, so you would think, who are they? Well, they may be athletes, and they may do this by actually training in mountainous regions where there is less oxygen around. Anyway, we're going to discuss polycythemia as it applies to a disease process. Now, we're going to assess these patients by doing a history and physical. I'm going to go over some of these signs and symptoms. They are at risk for impaired circulation, which can lead to gangrene and GI bleeds, CVA, thromboses, MI, or heart failure. And you want to monitor labs and hematocrit in these people. Signs and symptoms related to impaired oxygen delivery because of the sludging of blood. The patient will present with headache, dizziness, vertigo, tinnitus, visual disturbances, angina, or intermittent claudication. Bleeding complications, because in this disease there can be defective hemostasis, or there can be increased thrombus formation, which uses up platelets, which ends up leading to bleeding. There can be epistaxis, ecchymosis, and or GI bleeding. With a physical exam, you're going to find splenomegaly, hepatomegaly, and plethora, which is red, ruddy skin, and they usually have hypertension. The plan to care for these people include phlebotomy, and as Janice says, a good bloodletting will do the trick. Think of your medieval barber. Keep the hematocrit below 45%. They also may be put on chemotherapeutic agents, including chlorambucil and busulfan. And what this does is suppress bone marrow production. Now, nursing interventions are going to make sure that these people have fluids, to teach about diet, disease and treatment, and long-term complications, and monitor for them. And we're going to discuss that. Now, there may be altered tissue perfusion, so you're going to monitor for any CVAs. You're going to tell the patient to ambulate often, not cross their legs, or wear tight clothes, nor do we want them sitting for extended periods of time, such as on plane rides, because we don't want them to form deep vein thromboses. You want to assure hydration to decrease blood viscosity, and teach them about any anticoagulation therapy that they might be placed on by their physician. They're also at increased risk of bleeding, so they'll be taking stool softeners. Avoid blowing their nose violently. They'll use water-based lubricants for sexual activity, and soft toothbrushes and non-alcoholic mouthwash when they do oral care. If the patient is receiving chemotherapy, you're going to have to monitor for and prevent infection. And for severe itching, you can advise them to take cool, lukewarm baths, not to rub or scrub the skin, to moisturize with lotions that contain at least some oil, and possibly give them catecholamine. And finally, for pain, you always want to start with non-pharmacologic agents first. And this is the lecture on blood dysplasias.